Why do TNM staging interpretations vary for pancreatic cancer? Imagine trying to read a map that keeps changing as you look at it. That's similar to how doctors interpret the TNM staging system for pancreatic cancer. The TNM system helps classify how advanced a tumor is by looking at three key factors: the size and spread of the tumor itself, whether cancer has spread to nearby lymph nodes, and if it has metastasized to distant parts of the body. But even with this clear framework, interpretations can differ quite a bit. One big reason is that the staging criteria are updated over time. The American Joint Committee on Cancer reviews and revises these guidelines periodically to improve how accurately they predict patient outcomes. For example, the 8th edition introduced new size cutoffs for tumors and refined how lymph node involvement is categorized. These updates can change how a tumor is staged, which means a patient might be classified differently depending on which version of the system their doctor uses. Tumor size and local invasion are also tricky. Measuring how far a tumor has grown into nearby structures like blood vessels or organs can be challenging. Sometimes, imaging scans show involvement of major arteries or veins, which traditionally meant the tumor was unresectable or advanced. But with advances in surgery, some tumors once considered too invasive can now be removed. This reclassification affects staging and how doctors interpret prognosis. Lymph node assessment adds another layer of complexity. The number of affected lymph nodes influences the N category. The 8th edition divides nodal involvement into N141 to 3 affected nodes and N to 4 or more. But the way lymph nodes are examined, either through imaging or pathology, can vary between hospitals. This variability can lead to different staging outcomes even for similar cases. Another factor is tumor biology. The TNM system focuses on physical tumor spread but doesn't account for how aggressive the cancer cells look under the microscope. Tumor grade, which describes how abnormal the cells appear, can influence prognosis significantly. Some tumors grow slowly and respond well to treatment, while others are more aggressive. Including tumor grade in staging, creating a combined system called TNMG can help better predict outcomes. This biological aspect explains why two tumors with the same TNM stage might have different behaviors and prognoses. Limitations of the TNM system also play a role. It is mainly based on anatomy and doesn't include molecular markers or patient health status. So, two patients with identical stages might have very different responses to treatment or survival chances. That's why clinicians interpret staging results within a broader clinical context, considering other factors like overall health and tumor biology. Finally, differences in imaging and pathology techniques can lead to varied interpretations. The quality of scans, the experience of radiologists, and the thoroughness of pathological examinations all influence how accurately the tumor and lymph nodes are assessed. Small differences here can change the staging outcome. In summary, the way doctors interpret TNM staging for pancreatic cancer varies because the system itself evolves, tumor biology adds complexity, assessment methods differ, and clinical judgment is always part of the picture. It's important to remember that staging is a tool to guide treatment and prognosis, but it's only one piece of the puzzle. Always consult with healthcare professionals who can interpret these details in the context of your individual situation.